February 2016. Just going to talk about a few cases today. This one is a bit interesting. Have you heard of something called mystical fire? Okay. So, two young boys from a camping store. They went into a camping store, and they bought something because they thought it looked like a sherbet. They both had a small taste of it, and some got on their hands as well, and they both spat it out. It had a bit of taste on it. What do you reckon it could be?
A camping store?
Yeah.
So, is it something that helps keep you warm?
Yeah, possibly, but they thought it looked like a sherbet. So
You mean like a drink, or
you know those lollies?
Fizzy lolly.
fizzy lollies?
Do you have those in the States?
Mm.
No.
They have a
Citric acid.
they have a sort of a hard, sugary outside, and on the inside there's a powder that's got a tangy, fizzy nature to it.
Yeah.
Oh wow, interesting.
Anyway, I'll cut the story short because the mystical fire actually contains copper sulfate, copper carbonate, polyvinyl chloride. Okay, so I guess we can discuss what happens if someone ingests copper sulfate. I'm going to ask Rajan, do you know what happens? Copper
toxicity. No, I haven't look it up.
Yeah. First of all, they just had a taste, so it's probably not going to be a lot.
Not much. Yeah.
But
they get a blue tongue.
Green vomit. That's another.
So most of it's corrosive, but there are other effects if you take enough as well that can happen. Is Nick there, or is he muted?
Nick's there. You can speak up if you want, Nick.
That's all right.
Might be shy.
So it can also cause hemolysis if taken in large amounts, and you can also get hemoglobinemia because it's an oxidative agent. From the poison center, we haven't had that many that had any problems, I don't think.
The usual copper sulfate sort of calls we get involve kids at school, in high school, doing laboratory experiments. The making the copper sulfate crystals, and they accidentally swallow some or spray it in their eyes. So, they tend to be not deliberate self-poison, but, the school science experiments going wrong.
Totally, yeah.
Copper sulfate calls.
So these boys had mainly GI symptoms.
Presumably they put this stuff on the fire and it flames up and goes blue.
Goes green.
Green or blue.
Okay, so that's why the mystical fire.
Pyrotechnic sort of display.
Right.
I don't think it's a few. I mean, I'll use it a few or anything like that. I think
So
it was.
Did they check liver functions? Hepatitis?
I don't think they had any abdominal pain, but I don't think they did actually mention liver functions in this case. There was a case a few years ago that also mentioned there was a call to one of our Sydney poison centres that someone swallowed 10 grams of the copper sulfate crystals, and they mainly had GI symptoms as well. And when they did this problem, they had GI ulceration.
Yeah.
And the bilirubin that went up to 84 micromoles per litre.
Is there any value doing copper levels?
I would have thought so. Not in this case.
Not in
anyway.
this case, but generally, if someone's taken a lot, do you do copper level? Do you chelate them? Do you
Oh,
dilate?
yeah, that's what I was going to say next is once you get a copper level, you have to start thinking about chelation.
Yeah.
Or dialysis? You can dialyze these people.
Does copper get stored, or is what you see what you get in blood?
I think it's, like with Wilson's disease, that's a chronic copper overload syndrome. And I think the physiology there is, you do have copper storing proteins like ceruloplasmin, and there's probably others. Once those get overloaded, then you get free copper, and it causes a lot of problems.
Mm.
Kind of like iron, you know. Iron does the same thing with ferritin.
Mm.
Once you overload your storage mechanisms, the free inorganic iron just causes a lot of problems.
Yeah.
So this is sort of like that, although not as common because it's not a vitamin.
Mm.
But yeah, you know, they also like there's something called Bordeaux solution, which I think is copper sulfate also, right, or some sort of a copper solution, and that's used as an antifungal on a lot of on grape. Yeah, in the Bordeaux region of France. So I think they call it Bordeaux solution. Obviously, it's used outside of France also.
Maybe we should go there and check it out, Ray.
Let's go. Let's do some field work. We got to go there now. A lot of the really nasty case reports of copper come from India, where it's used for tanning and leather work and stuff like that. And boy, it sounds like a nightmare when you have a real bad copper sulfate. It just causes all kinds of just perforations in the GI tract and the methemoglobinemia and the hemolysis. You know, we had a lady in our part of the country. We actually have a lot of copper-based compounds that are used as antifungals, but they're not inorganic. They're actually partly chelated, and they're called copper ethanolamine complex. And they're designed to release copper very slowly as antifungals for swimming pools. So, and these pool chemicals, they're like deep green. They look very attractive, and people drink them accidentally. You know, kids or maybe old people with dementia. And so we had a lady. She was elderly. She had Alzheimer's. She was left alone next to the pool, and she drank a bunch of copper ethanolamine, and she had very mild copper toxicity. She had mild pancreatitis, mild, you know, GI tract corrosive sort of injury. They actually did an EGD on her. Mild hemolysis. We got the blood smears, and it showed spherocytosis, which is what happens right before the red cells burst open. They actually become really round and spherical. So she had these really mild changes. They were very interesting, and it was almost like copper sulfate light, you know, a very, very mild version of this. She didn't have methemoglobinemia, and her LFTs were just a little bit bumped. And she recovered after like 3 days. She did just fine. But you know, we ended up sending a copper level on her, and the copper level was like 4 or 5 times the upper range of normal. I don't remember the numbers, but we decided not to chelate. We said, you know, let's just ride this out because all of these symptoms are pretty mild, and we decided not to chelate her, and she did okay. But I think, you know, if you get anything more severe, then you have to think about either exchange transfusion for the hemolysis and the methemoglobinemia, or you have to start thinking about chelating agents. None of which are perfect, as you guys know.
Are these cities purely from injection or from your environment? But you know, like that, people work with copper-containing chemicals, for instance.
Yeah.
Sorry, is it possible to absorb copper salts from environmental exposure, such as through the skin, or do you have to take it by mouth?
That I don't know. I don't think I've seen a report of like a topical exposure of copper. You know, people use these copper bracelets. Have you seen these?
Yeah.
I really believe in them.
That's metallic copper. That's not ionized copper. That's actually just the element itself.
Is that right? Okay. And you know, I mean, I've never seen any problems with them. People think they have magical properties and stuff, but I haven't seen anybody get copper toxic from that.
I mean, lots of people handle metallic copper, you know, electricians and all the rest of it.
Well, yeah.
You know, I don't think metallic copper is such a problem. You know, as you say, you can get copper-containing jewelry and so on.
Yeah.
If you're exposed
I think it's the inorganic salts.
Yeah. You know, those sorts of chemicals must be used in industry all over the place.
Totally, yeah. Yeah, I think you're right.
You never get calls.
Just for the Fiji guys, obviously they were talking about copper sulfate. There was a or children who took some blue crystals by mistake. The main things, in summary, is they can get GI corrosive effects, but sometimes if they take enough, possibly hemolysis and methemoglobinemia. Great. We'll move on to another case. Over 45-year-old man who had a history of depression intentionally ingested pentobarbital. They're not sure how much he took or what formulation it was. And his mother called the ambulance. When the ambulance arrived there, he was in an asystolic cardiac arrest. And he had return of spontaneous circulation after advanced cardiac life support, had some adrenaline, was intubated and ventilated, and had a heart rate of 110, but tachycardic, and blood pressure was normal after adrenaline, 80 mics per minute, so still quite high. So quite lethal. So let's talk about pentobarbital. It's a very old kind of.
Is this
a veterinary product?
Yeah,
Or something?
yes.
Yes.
I wasn't bought over the
Internet of
No,
euthanasia sites or something.
No. So
It's on the Denkital.
yeah. So I'm pretty sure this was a veterinary preparation.
It is. Is it capsules or the injection?
It must have been the. Well, they said they ingested it,
Yeah,
so,
okay.
but they weren't sure what kind of formulation.
Formulation, yeah.
Yeah.
Because pentobarb's in the letha barb, the
Yeah.
green dream
Yeah,
that's
that's right.
used to euthanize
Yeah.
animals. So
Yeah.
it's very concentrated. It's about 450, 325 milligrams per mil or something. It's a very concentrated
Yeah.
solution.
Yeah.
The reason I know the figures, we had a call from Wonthaggi Hospital just the other week. A vet nurse had sprayed some in her eye, and may have swallowed a little bit. You know, she was assisting in the putting down of an animal, and some of the stuff sprayed back in her eye. The letha barb. The vets call it the green dream.
That's right.
So getting back to what.
But we've had people have injected themselves with it here over the years, haven't we?
Yeah.
But it's short acting, isn't it?
Yeah. Well,
Well, it doesn't need to be.
is it?
Any more than that.
Well, we think it.
It's
Well,
a permanent effect.
I think. Well, pentobarb is a barbiturate. So, do you guys in Fiji use pentobarb or any phenobarb still?
Yeah.
That's all right. It's a short-acting barbiturate, but then in this case, it just depends on the dose, I think. So this patient was, as I said, intubated. He had some charcoal down a nasogastric tube. They did an echo. And I guess the question is, what would you do from now? Would you just support him, or would you? There are other ways of probably trying to eliminate this drug. So he's got it's got relatively high requirements for inotrope.
Can you dialyze it?
Yeah, you can. Well, that's the controversial part of it. Can you dialyze, and is it worthwhile dialyzing pentobarb? Because it is, as I said, we said it's a short half-life, and is it going to actually change the course of management? I suppose is the question.
If it was longer acting like phenobarb with cardiovascular compromise, you'd probably dialyze as well as charcoal. But pentobarb, you're right. You just ride it through.
So
Can you do urine alkalization for lethal barb?
yeah, alkalization as well, I suppose. But
Well, I don't know. You believers.
depends.
Yeah.
Do you
Half-life's 15 to 48 hours.
do you guys alkalize? Do you alkalize the urine for barbiturates?
You know, for phenobarb, again, I think it's controversial. I think it's pretty low low resource intensive when you have a really sick phenobarb case. And so, you know, if you're up against a wall and you have to choose between starting a bicarb drip and dialyzing someone, I think starting a bicarb drip makes sense. Beyond that, I don't know that it helps that much. and most
I've
cases.
stopped doing it. I just do MDAC plus or minus dialysis, but
What's that?
Multi-dose.
Yeah, but all three of those, I don't know which one. I don't know that I've ever seen a head-to-head comparison of multi-dose charcoal versus bicarb versus dialysis. So,
Yeah.
I think the thing with MDAC is you have to have a GI tract that's moving.
yeah.
And, if these people have ileus, so it's hard to push push charcoal down the GI tract for that reason. But yeah, I mean, I think it's in the things that you would consider if someone's really sick.
Yeah.
I think the answer, I mean, it's hard to know. As Grace was alluding to, the evidence for dialysis of pentabarb it's not very great. So
For pentabarb.
Pentabarb,
Yeah.
So for short acting.
Okay, now have you guys seen concretions from any of these barbiturates? The way that aspirin can form concretions. You often read every once in a while that barbiturates can do the same thing.
Right. Okay.
I don't know if I've ever seen it. Maybe I haven't seen that many of these, but have you come across a case where it sounds like the person's just not getting better, and in fact they keep absorbing stuff from their GI tract based on levels?
It's hard to know. It's usually the long-acting barbiturates like phenobarb that when they take a big enough dose, they're just comatose for a week.
Yeah. Right.
And I'm not sure whether that's ongoing absorption or whether that's just long-acting.
A lot of fat stores or something. Yeah.
So maybe I asked our registrar, what do you reckon? So he's intubated, a week later, he's got no kind of neurological improvement at all. Are we done?
A week later.
Yeah, a week later.
And I want to take his organs.
And you want to take his organs.
Which is great.
With pentabarb.
I mean, you probably have to establish is he brain dead or not. Plus or minus EEG, plus or minus MRI, a neurological consult, I guess. And if he is brain dead, stop it. But if he's not brain dead, and we got a causative agent which is causing that, I think we probably have to go further.
So he's got no neurological function.
So he's brain dead.
Well, clinically he's got no neurological function.
His tests for brain dead are positive.
Yeah. And a week after, so if the test for brain dead is positive, so we can stop here.
Yeah. So the question, the call that
I think that's a trick.
I sort of see there's a trick.
Because the brain death, at least in the U.S., the brain death exam checklist, one of the items on the checklist is they can't be on barbs. Yeah. Or if they are on barbs, you have to wait like a long time. Because of this issue, they can sure act brain dead, even though they're not.
Barbiturates and baclofen are the two classic brain dead mimicking.
But don't give away both his kidneys. Just give away one, just in case.
Half his liver, one lung. One eye.
But will it be kind
one eye.
on board?
Well, not at the moment, because we don't think he's brain dead, really. So the short and long answer is I think we need to wait a bit longer. This is short-acting barbiturate, but this patient actually had concentrations done, and his concentration, like I don't have it here, but they were sky high, and it lasted like that for at least 3 or 4, 5, 6 days before it actually started coming down. It actually stayed quite high for that period of time, so there might have been a massive load of ongoing absorption that was happening. So eventually he regained neurological function, and probably took him about 9 days to get extubated. So I guess then the question, this guy. So I guess then the question is, would early dialysis maybe have taken off some of that load? Obviously, we can't get pentabarb levels done right that day, but I just wonder if he was unwell enough to have an arrest. Obviously, had a large enough dose to cause cardiotoxicity. Maybe maybe early dialysis would have helped in this patient. I don't know, or even decreased his length of stay. Hard to know.
You've had a cardiac arrest and you're on 80 of adrenaline.
Yeah.
Wait a day before you do anything.
Yeah. But even if they had started on day 1 or day 2, I mean, according to the concentrations in his blood at that time, it would have had similar effect as on day 1. So I'm assuming there was ongoing absorption. But it just goes to show that even though it's a short-acting barbiturate, supposedly, you can have concentrations, concentrated for at least a week. So I think the evidence is very sparse on these types of ingestions. So I think we need more, more patients, but with more concentrations done on their bloods to actually form a evidence-based opinion on whether we do need to dialyze some of these. I mean, in this case, we didn't know how much he took, but I'm sure he took a lot. Yeah.
If you had access to levels, would you wait till the level was 0 before you thought, well, now he's brain dead for sure. He's been 2 weeks now. The level's 0. Let's take his organs.
It just depends what's in the brain, doesn't it? I mean, even though it's 0 in the blood, we don't know how
Yeah,
much
but
is in
if
the
the
brain.
levels are high, then they're going down, and they go down to 0, then how long do you wait after that before you...
Maybe you wait a week. I don't know the correct answer. And if
Check the level on CSF.
Yeah.
Sorry?
Check the level on CSF.
CSF.
Well, maybe you could check the level on CSF. I don't think that's a bad idea.
There was that case last year, wasn't there, Race, about, and I still can't believe it happens in this day and age, wasn't there some person in New York who woke up on the table after baclofen? They were trying to take her organs?
Was it baclofen? I think so, yeah. I think I read about that.
Yeah.
With baclofen, it's hard to get levels, so...
Yeah, I know.
In an academic center.
I think
I
the
mean,
record
with the barbiturates, though, if the level's 0, I mean, we get phenobarb levels all the time. I'm not as familiar with pentobarb. But if the level's 0 and the patient's not waking up, I'd be pretty confident that they were brain dead. I mean, I know that we're looking at blood levels, not brain levels, but just physiologically, they do equilibrate at some, some rate. And if the level's 0 in the blood, then the chances that there's a high enough level in the brain to cause that much of a coma, that just doesn't, I don't know, that just doesn't seem to make sense,
Yeah, given that it was an old anticonvulsant, and we used to check levels all the time to see whether they're therapeutic, and they were walking around non-comatose with phenobarb in their system.
Yeah.
Okay. All right. Any questions from Fiji about that? I'm sure you may see a few phenobarb cases.
Oh, did you, Ansem, were you able to find whether this is radio opaque or not? You
mean on imaging? Do you mean? Or?
Yeah, on X-ray. Yeah.
I can't remember if they did imaging. I don't recall them doing imaging on
okay.
or anything. So.
Okay.
I think they just did a chest X-ray.
Okay.
Is that looking for concretions?
Yeah, I don't know if the barbs are considered one of those that are considered radio opaque.
I
thought so.
No, they're not in a slow release formulation, are they?
No.
Oh yeah. I don't know.
All right.
Cool case.
All right. How about this one? Something a bit controversial, but we'll talk about it anyway. And a common problem. So 84-year-old female with a past history of atrial fibrillation, congestive heart failure, and type 2 diabetes. She's on 500 micrograms of digoxin per day, atenolol 50 milligrams, and ivermectin 5 milligrams daily. Ivermectin is a negative chronotrope. So she presents with 2 days feeling unwell, vomiting, poor oral intake, and confusion. She hasn't had any of her digoxin for 24 hours. She presents with a heart rate of 25, blood pressure of 110, systolic, What would you do now, I suppose?
I would stop those medications.
Exactly right.
Yeah.
Yeah.
And she's symptomatic on that heart rate.
Yeah.
That
Yeah, so what would you give for the-
chronotrope? So stop that.
What would you give for the heart rate? 25.
I probably will treat that bradycardia with perhaps some atropine.
Well, you can give some atropine, see if it's responsive.
And have a look at the ECG to see if there are any blocks.
Yeah, so she was given atropine, 600 mics, and her heart rate came up to 60. Even though her blood pressure was still okay at that stage, she was alert but confused, and the ECG is just slow atrial fibrillation, no evidence of anything else. They did a gas, her potassium was 4.8, and the renal function, her EGFR came back at 40. And
Is that normal? Oh, 40%.
EGFR 40.
Over 90 is normal.
Over 90 is normal in our range, yeah.
Isn't trouble with that?
Yeah. It's measured for age, yeah.
Okay.
What's the ditch concentration?
Yeah, it was 9.8 nanomoles, I think nanomoles per liter.
The digoxin.
Yeah.
Well,
What's normal?
So,
that's about 10 times.
10 times.
1 to 2 is normal.
what would you do in this circumstance? I suppose.
Give us some DigiFab.
Yeah.
No.
And how much?
Yeah, is she in a place where she has, where you have access to digibind antibodies?
Yeah, we do. And the question is, if you're going to give it, how much would you give in this patient, and what are your indications, I suppose? Maybe I can ask Raja.
I mean, if you can treat her heart rate with atropine, that normalizes it, and this is probably going to be a chronic digoxin toxicity rather than acute digoxin toxicity. Still haven't got my head around the controversy about that precisely, but I probably wouldn't give it. I guess I'll probably just wait and see and stop the digoxin for now, and wait and see to get the digoxin eliminated by itself.
Yeah. Well, if a heart rate stabilized at 40 and a BP, let's just take that scenario first. So if a heart rate was around 50 to 60 and the blood pressure was normal, would you give any digifab raise to this patient? With nothing.
Potassium's not too high.
Yeah, I would. You mean if the heart rate increased with atropine?
Yeah, and just stabilize without any other support. So she had a normal blood pressure, heart rate was 50. She was still mildly confused and a bit.
And you said the level is 9 and normal level is 1 to 2?
Correct.
And she hasn't taken it for 2 days.
She hasn't taken it for a day.
So that's a really high, scary level to me, and I'm like, what's the harm? It's...
The other thing, she's probably had a level that's been super therapeutic for weeks.
Long time, yeah.
Yeah.
So why rush if she's stable is the other argument.
Yeah.
The other thing I was going to ask you, do you have access to digoxin concentrations that are bound and unbound? Like, does your lab differentiate it?
We don't have fractionated dig concentrations. We just have total.
Yeah, so that's the problem, isn't it? You give 1 or 2 or 4 or whatever vials, and then your level comes back as 15 or something, and you've got no idea where you're at.
Right.
Yeah.
That's a good point. I mean, I wouldn't because she stabilizes with the atropine. I wouldn't really, have a battle about this.
Yeah.
But my style would be just to give digibind at first because she's not just on dig, right? She's on several other medications that could cause a bradycardia.
Correct.
And I want to get dig out of the equation, so then that's one less thing I have to deal with. And then I can deal with all the other antidotes that you're going to consider in a situation like this, including atropine, glucagon, possibly calcium. Is this person on a calcium channel blocker too, or?
She's on a beta blocker.
He's on a beta blocker, right? Yeah. So to me, that's why. I mean, I'm glad she stabilized with atropine, but my approach to this is just get the dig out of the way, and then deal with the other stuff. And if the digibind helps, then you know that it was dig. And if it doesn't help, then you can go down and deal with the beta blocker, which is a little bit of a more complex resuscitation to me, with glucagon and pressors and other stuff.
Yeah.
So that's just my style, but I guess you can't be faulted for getting somebody better with just a little bit of atropine.
Yeah. I guess if you give the digibind and the heart rate and blood pressure stay the same, then you really don't know what's going
But how
on.
much would you give?
Yeah, that's another question. But
Well, if you have the weight, you could just calculate. I think it's the weight times the level divided by 100.
yeah.
So.
Well, it just depends. So she's 84 years old, and it's all about the volume of distribution. So the volume of distribution in an elderly patient with renal function that's really impaired and half that of what it normally should be.
Uh-huh.
The volume of distribution is going to be much less. So it's going to be like 3 to 4 liters per kilo rather than the 7 to 8 that you would see in those truncated formulas that people use to calculate the digoxin concentration, as well as the fact that what you're trying to bind is what's in the intravascular system, and you're not going to get everything that's in the total body concentration anyway. So, 1 to 2 vials would probably bind everything in.
Yeah, I was going to say empirically, if you don't have a level, I'd probably give like maximum 3 vials.
Yeah. And if it doesn't do much after 2 vials or 2 or 3 vials, you're probably not going to be doing much.
Right.
You bound everything in the intravascular system, and it's hard to know if it's all on what's in the intravascular system or if it's the offset from the receptor on the heart. It's hard to know. But if you take out everything, if you bind everything from the intravascular system, and nothing happens, then I probably wouldn't go on giving more, especially if the patient has already got a normalish heart rate and normal blood pressure. So in this case,
But if her heart stops, you'd give 10.
yeah, that's right. Why not?
Yeah.
Why not? In this case, she had 2 vials, and I think it didn't do anything. Basically, she went on an isoprenoid infusion, and I think probably the 2 other drugs that she was on, atenolol and ibuprofen, were probably contributing more to this than the actual dig itself. So I had another case similar to this, but she also had a level around 8 or 9. That the blood pressure was normal and the heart rate was on 40 to 50, and we just watched them because they were asymptomatic otherwise. And after a few days, it came down just with fluids and ceasing the medication. Another point to note is that a lot of the chronic digoxin overdoses, chronic digoxin toxicity, I should say, they have 4 or 5 half-lives to get to that kind of steady state concentration. So you would think that if they're at home and they're not too unwell, that they're probably quite stable prior to coming to the hospital. So
Sure.
I think some of these are incidental, unless they come in obviously bradycardic or severely dehydrated. It sounds like most of them come in dehydrated and sick from an intercurrent illness, which puts them into renal failure, and then incidentally you get a dig concentration which is elevated because of that. So I think we're finding a lot more nowadays, even though we're giving digibind in some of these patients, it does nothing to their heart rate, and a lot of them are on beta blockers and other medications. So in the chronic setting, I'm not in this patient, sure, but if their heart rate was constantly bradycardic, would just take it out of the picture. But if they had normal blood pressure and a pretty good heart rate, I might just watch.
It's a bit hard to ignore a heart rate of 25 and a digital
Yeah.
9.8, and you have an antidote.
Yeah. Yeah. So, yeah, I don't know. Is it?
Have you heard that giving dig will throw someone into heart failure?
Giving
dig.
I mean, sorry, giving digibind. Giving digibind.
Oh, right, yeah. Well, I've never seen it personally. It has been reported. I guess if your ejection fraction is so precarious that you're reliant on a little bit of digoxin inotropy, then it's possible.
Yeah, I don't think I've ever seen it either. I don't think my colleagues in California don't really think that it's a big issue.
Mm-hmm.
The other thing is there are certain chronic disease states that force the body to create digoxin-like substances,
Yeah.
such as cirrhosis, pregnancy, renal failure, heart failure. And whenever you measure dig levels in these people, even if they've not taken any digoxin at all, they have like a mini dig level, like 1,
Yeah.
1.5, something like that.
Yeah.
I don't think a level of 10 is all due to heart failure, but every once in a while you can check a dig level on like a cirrhosis patient or even like a pregnant woman, and it comes back positive. Like it's a very small elevation, and it's due to these endogenous digoxin-like substances. That's what Goldfrank's calls them. They call them EDLS.
Yeah.
And they're thought to have some kind of physiological role, I guess, in hemodynamic, regulation that has been not very well worked out. What's really interesting is that there's a trial in women that are like eclamptic, like eclampsia, with high levels of this endogenous dig-like substance, where they're actually giving Digibind as a treatment for preeclampsia. Like I said, this is just in the trial phase. It's not really standard of care, obviously. But it's just interesting that people are using these things as possibly a target for therapeutics.
Yeah, wow.
And I wonder, just as giving the antidote, if you have severe renal impairment and you don't fix that, I just wonder if the binding of the Digibind to the digoxin eventually just becomes unbound again, whether it has anything. Do you know a rough time of how long it binds for?
I thought it was like 3 days, and that's enough time for the spleen to clear out this complex.
Yeah.
And then after 3 days, if you've got a rise in your dig level, you should redose the Digibind. But, that's like urban legend. I don't think I ever read that. I think I just heard that from like a cardiology doctor or something like this. And who knows if you can trust those guys.
Okay. All right. If there's no other questions, I might move on to maybe our last case. Any questions from Fiji? Are you just happy listening for the moment? Great. All right. So maybe just one more. So this one I just thought it would just be a kind of a good learning case. So Slow K, do you have that in the States? It's a potassium supplement. It might be under a different name, but it has
Like sustained release potassium chloride or what?
Yeah.
Slow K or Span K.
Yeah.
Span K, Slow K, KSR.
Yeah. So they took 50 times 600 milligram tablets.
30 grams.
Yeah. 42-year-old lady. 1 hour before presenting to hospital, she was pretty okay. They did an abdominal X-ray. Do you think they can find it on abdominal X-rays?
I don't know if the radio bake or not. I doubt it is.
Oh, it's metallic, so
Well,
It's radioactive.
Potassium is metallic, but potassium chloride is still metallic.
well, good question. Potassium.
it's a light metal.
Yeah.
Not a heavy.
It's slow release preparation too, and a lot of slow release preparations show up on X-ray. A negative X-ray doesn't mean it's not there, but a positive one may be helpful.
So they could count at least 25 of these tablets on the X-ray. So we think that the patient was probably telling the truth, or at least half truth at least.
Yeah.
Are we worried about this?
Yes.
Okay. Potentially was. I mean, she's well at the moment. I mean, this was a kind of an urban hospital, so no intensive care unit in this hospital. Any urgency to move them at that point? Can we keep them there and just watch them? And what are we watching for? I mean,
You probably have to measure the serum potassium level.
say it's normal.
That is normal, but
Say it's
it's going to
full.
go high. It's going to go up.
And in what time period are we thinking that you may get rises in the potassium level?
Don't know.
A few hours. It'll be hours.
It's a slow release, so it'll be.
It's a big overdose. It's 8 millimoles of potassium per tablet, so it's 400 millimoles.
Yeah.
If this person's 75 kilos, it's over 5 millimoles per kilo.
Yeah.
Anything above about 2 millimoles per kilo in a person with normal renal function.
Yeah. So we're thinking about
renal function, of course.
we're thinking about 5 millimoles per kilo of potassium potentially ingested, 2 millimoles per kilo potentially fatal. So this patient could go downhill, even though they look quite well at the moment, 1 hour post their ingestion.
1 hour, is it?
Yeah, 1 hour post ingestion.
Would you lavage it?
Whole barrel?
Should lavage it?
It's an hour?
Yeah. I mean, you could, but we don't have the equipment, and I don't think we have the staff to know how to do it anymore.
Whole barrel?
Whole bowel irrigation?
That's what I was thinking. I'd probably advocate for whole bowel.
Yeah.
It's a safe release.
Yeah.
You know, you've got a potentially deadly ingestion.
Yeah. Would charcoal work in this patient?
No, it's metal.
No. Yeah, so no to charcoal, but whole bowel potentially, yeah. If she develops hyperkalemia, the standard kind of emergency department management, we would give
insulin dextrose, calcium gluconate for cardioprotection, but that's probably not going to be enough.
So what are our endpoints? And what else can we do then? Dialyze. And when's our trigger? When do you think we should be doing it? When they're getting arrhythmias? Or?
When the potassium start to rise on a BBG, which will very likely will happen. So we can actually preemptively plan for that. So she can go to a place that has HDU or ICU support with hemodialysis facility.
So good point. So potentially we think this patient may go downhill, and if they do go downhill, they're going to go downhill pretty quickly within a few hours, you'd think, if they start to get potassium rises. So whole bowel irrigation, treat the potassium, and prepare for dialyzing this patient. When would you trigger? Well, I don't think you would wait. If they're starting to get 6 or 7, you would probably, with this risk assessment, you would probably, get prepared to start dialysis and get.
Is she symptomatic? I mean, is she even vomiting from this ingestion?
No. It was early when the call was made, so no, she wasn't actually symptomatic from it.
Okay.
Yeah.
So if potassium is 6 or 7, would you just stop whole bowel and start dialyzing? There's no point doing both there, is it?
I don't know. I mean, I feel like this is a sustained release preparation, so you're really going to be adding to the bloodstream very slowly.
Yeah, and if you're starting dialysis, you just
like CVVH or something that's continuous at the same time as whole bowel irrigation. I mean, logistically, that's very hard to do.
Yeah.
You almost want to do like a continuous cleaning of the blood as this stuff gets poured into the bloodstream. You want to clear it out. Whereas with dialysis, a session will last 4 hours. If that 4 hours doesn't coincide with the peak absorption, then you may have missed your opportunity. And with the sustained release preparation, who knows when the peak absorption is going to be?
Yeah, and anything invasive like dialysis. I mean, people who take bowel preps for things like colonoscopies, within 4 hours, there's not much left in there, and it's a fairly commonly done procedure. It doesn't require intensive nursing. You could just give them, that stuff they give people for colonoscopies. And,
but you need to give like 2 litres an hour. And you have to put
as much as that.
Yeah.
Plus, they have to be able to sit on a toilet, which is hard to make. It's hard to move them from the bed to the toilet while they're getting some sort of a renal replacement therapy going on. So, to me, that's the logistical challenge here. Is you have big tubes coming out of them for the dialysis, and at the same time, they got to go number 2.
Yeah, I would think whole bowel would be good to prevent dialysis and treat the ingestion. And once you establish hyperkalemia, then you just get on with dialyzing and stop the whole bowel, I would have thought.
Yeah.
It doesn't stop instantly. If you pump a bit of that stuff in at the top end, you don't stop pooing for quite a few hours after that.
It just depends. I mean, if it's still in the bowel and still absorbing, if it's such a massive concretion, if it forms a bezo or anything like that, and whether that's going to help.
What about good old Kxalate? Are you guys using Kxalate at all? Sodium polystyrene sulfonate?
No, have you? Do you guys use that?
I used to use it all the time, and then I guess there's newer reports now that it can cause bowel necrosis.
Yeah,
But,
yeah.
you know, that's a binding resin. It'll just bind the potassium in the gut.
Yeah.
Why don't we throw some Kxalate down?
In this situation, is it going to make much of an effect? I'm not sure it will to the blood concentrations. I mean,
that's a good point.
Yeah. I mean, insulin dextrose probably just help redistribute it back into the cells.
Right.
Yeah. But, it's just,
So might sound silly, but if you can see it on the X-ray, can you ask the gastroenterologist to scope her, and probably suck it out if you can see it on the X-ray?
Depends where it is.
Depends where it is.
If it's in the stomach,
And they become congealed and gelatinous, and you can't grab them.
Okay. So the question was, can you gastroscope it out? And
Yeah, that's a great thought.
Yeah.
I think if they took like an extraordinary, ridiculous amount, like 200 tablets, and they're just sitting there as a clump, you may consider something like that, or even gastrotomy or some heroic thing. But generally,
yeah, it's hard to do if they're, by the time you think about doing it, they've arrested it. That kind of thing.
One of my favourite potassium stories is a young intensive care nurse in her 20s who, in an attempt to get her boyfriend back, took 30 of these tablets and then realised what she'd done and came to hospital. And so she was quite compliant with our treatment, so we decided that we'll do whole bowel irrigation to prevent any absorption. So we put her in a resuscitation cubicle, put a nasogastric in, and she's getting the polyethylene glycol. And so then the boyfriend, or the ex-boyfriend, comes in to visit her. So he comes in, he pulls the curtains in the resuscitation cubicle and sees her in a hospital gown, sitting on a commode with a drip in one hand, a nasogastric tube with all this stuff going in. And in my mind, I'm going, he's not coming back. She did fine.
That's the true
This
test.
patient as well. Yeah, this patient as well did fine. So I'm not sure if they took 50 tablets. But
What did the K get to?
the K only got to 5.4, and that was
With whole bowel? Oh, with whole bowel.
I think with whole bowel, yes. So she didn't need any. Well, she didn't need any hemodialysis, and I don't think she required much from the medical point of view of her hyperkalemia. But
Whole bowel is more of an aversive therapy that would convince them not to do it again.
So that's that. Any more
Great.
cases before we wrap up today? Race? No?
Quick question for you guys. Do you guys have the Bigatran in Australia?
Yes, we do.
Yes.
And do you guys now have the antidote for it?
No, I don't think we do. There might be some hospitals in Australia that may stock it, special access type of thing, but what about you guys? You got it?
We've it's been FDA approved, and I think all the hospitals are scrambling to get it as if it's a magic bullet. And it probably does have some role in reversing dabigatran toxicity, but there's a lot of discussion here about whether it's going to be enough because it's not really a procoagulant agent. It's just an antibody that reverses dabigatran's effect, but once you've started bleeding, you've still got to stop the bleeding somehow. And we've had a lot of discussion about where it fits into the bigger picture of things like fresh frozen plasma and prothrombin complex concentrates. So we had one case at our hospital where a guy came in. He's on dabigatran and he's altered. He's had a fall and he's got a big head bleed. just a giant head bleed the size of a grapefruit inside his brain, and the question becomes, does that person get the reversal agent? And even if he got the reversal agent, it's not going to make the blood go out of his brain. I mean, it's there. So then what do? Do you give other things on top of that? So that was kind of an interesting case discussion that we had, just about what you would do in a case like that.
So if that guy doesn't get it, who's going to get it?
Do what?
If that person that you just described doesn't get the antidote, then who would?
Well,
I'm not saying it's going to make a difference, but
Right. Yeah. No. I think everyone agreed that if they had the antidote at their hospital, they would give it. At that point, we didn't have it at our hospital, so we opted to give FEBA, which is an activated, prothrombin complex concentrate type agent, just to help stop whatever bleeding was going on. And then he was taken to neurosurgery. No, actually, he wasn't. Neurosurgery consulted, and they basically concluded it was a non-survivable injury, so they opted to not go in and do any operations, and he was made comfort care. But yeah, I mean, that's the issue. Is, do you give it to someone preemptively after they've come in for an overdose, before they start bleeding? After they start bleeding, is it going to be enough? And does GI bleeding? I think the two major types of bleeding that are seen with these patients is GI bleeding and head bleeds. I guess every once in a while you get intramuscular hematomas that can be really bad. But with GI bleeding, I think giving the antidote makes a lot of sense, and then transfusing them to make up for the blood loss. With the head bleeds, I don't know. I guess I'm still a little bit skeptical about whether this agent's going to do much in the long term.
Yeah. And I think with overdoses, as you mentioned, I mean, preemptive giving of the fab is, I mean, a lot of these patients would just do well, and some of them might not get bleeding. So I don't think I would be giving it to patients. And a lot of the case reports have been written up. People have gotten better, and
is it a fab?
You're totally right.
It's a fab, yeah.
It's a fab.
And the other thing about prothrombin complexes in the Bigatran uses, it's probably not going to work because it's just too low down the coagulation cascade to actually probably help at that stage. So if they're bled, that's probably it. I don't think there's much you can do. I mean, if you had it in the hospital, yeah, sure. But as you say, prognosis will be poor in those patients.
Yeah.
The disappointing thing about it is they should have called it Fabicatran. The antidote. It just makes sense, doesn't it?
Well,
rather than something.
Well, the Bigatran, the trade name is Pradaxa, and
Plaxabine.
Like joke, the devil does not wear Prada. The devil wears Pradaxa.
All right, great. I think that's it.
Thank you, guys.
Anyone? Thanks from Fiji for coming. If we don't have any cases to discuss, no. Okay. Thank you for coming. We'll catch you next time. Thanks, Nicholas, for coming. Thank you, Race.
Yeah. Thanks, Nick. Thanks, Anselm.
All right. We'll catch you next time.
See ya.
Bye-bye.